do is hit the record button, just so that everybody knows that we are recording. Welcome. My name is Lisa Lavinia, and I am the VP of Business Development here at VSys. I'm relatively new to the organization, so I am excited to get to know you all and work with you as we do these Voices webinars. Welcome to our webinar today on volunteer roles with vaccination clinics. Couple housekeeping announcements before we begin. First, as I said, this webinar is being recorded. The recording will be up on the Voices website, which you can access from VSys1.com, our normal website, in a couple days, along with this slide presentation. We also are putting some, all past Voices webinars are up there if you'd like to explore some of them, virtual volunteering, awards and recognition, different topics every month. And we also will be adding this month a recorded webinar by Dana Litwin and Todd McMullen, two of our voices, on how to best organize and implement virtual events, such as awards or recognition events. So take a look for that. It should be appearing in early March up on that website. And we hope that these tools give you some help as you manage in this current world. Second of all, everyone, all attendees are currently muted. We encourage you to use the chat box to let us know if you have something you would like to share. Let us know and we will unmute you, but we do keep everyone muted just for noise control during these webinars. When you look at that chat box, we ask you to look at that Send to pull-down menu and select all participants, because we tend to find that you all share ideas that benefit the entire audience. So we'd like everyone to see your chats unless you want to tell us something privately, and then you can leave it to send just to host. But take a look at that. You can start, if you would like to test it, by just putting in where you are from. So I am going to now launch a poll question for those of you that are on the computer attending this. We're trying to get a feeling for who is already doing what. As we noted, we're talking today about how volunteers support vaccination efforts, and we're going to start our conversation by having a couple VSys clients share what they're already doing. And then I will turn it over to Joan, Todd, and Jared, our experts, our expert voices, to share with you what they're hearing and what they found across the industry. So if you have a chance, take a look at that poll question. And in the meantime, I am going to continue us moving along. Let's see. I don't see Susan on, so I'm going to see if, oops, excuse me. If any of the folks from Providence are on, Johanna, I see you're on. I do not see Brenda yet. I'm wondering if you can share with us a little about what you are doing with vaccination clinics and volunteers. Can I put you on the spot?
Yes.
We hear you, Joanna.
You do hear me? Oh, okay. So what was your question again? I'm sorry.
That's okay. Can you tell the other VSys folks on the phone what you all have been doing at Providence with vaccination clinics in terms of volunteers? What are you using volunteers for?
So a mix of things. They're filling clinical and non-clinical roles. So we have volunteers who've been brought on as vaccinators or nurses, pharmacists, even pharmacy students, as long as they have a pharmacy intern license and independently administer vaccines. And then we have volunteers who are just, filling the non-clinical roles, checking patients in, scheduling patients for their second dose appointments, just kind of helping with that throughput, making sure things are flowing well. And then some of the other clinical roles, besides just being the vaccinators, they have clinical staff who are drawing up the vaccine, and then they have clinical staff who are watching patients after they've received the vaccine to make sure there aren't any adverse reactions.
Cool. And Susan Gavin is also on. If Susan, you would like to tell us a little bit about what you all are doing. Do I have Susan Gavin? All right, I'm going to say that Susan Gavin we seem to have lost, so we will let that go. I will, in the meantime, share the poll results with you all. I think you can see these now. And just to give you a heads up for those of you that don't see this on your screen, we asked if your organization is currently using COVID vaccination conducting COVID vaccination clinics. And 50% of the audience said yes. 3 groups said no. 1 group said we're planning to, and a couple people have not yet answered. So it looks like this is something that is happening out in our community with our clients. And when asked if volunteers currently assist with vaccination efforts, we had 19% say yes, 44% say no. So we are not really using volunteers yet for vaccination clinics in most cases. And we have a couple folks that are exploring this option. So that was our first poll question, and we will let that go. Let me get that off the screen. And on that note, I am going to move us over to Joan and turn it over to you, Joan.
Joan, you're muted.
I apologize. We've been looking for some time at this COVID-19 vaccination practice and these practices, and even since our last session last week, there have been changes in how the vaccine is being distributed. So I'm here to give you an overview, way up high. Many of you probably are familiar with this information already, but just set our perspective here about how we're going to approach the topic this morning. And last week, AHA, the American Hospital Association, had a podcast. And they had 3 CEOs from systems across the country, or 3 leaders within their organizations. One system was Trinity, one system was Ascension, and one system was LifePoint Health. So it's very interesting to hear the perspective of the leaders of those organizations. But one of the quotes struck me. And the quote is, and you've heard this in many versions before, but I want you to listen with your volunteer leadership ears, and that is, vaccinating the American public against COVID-19 is the greatest public health feat in our lifetime. And so, from that perspective, I think, well, what does a volunteer leader think when they read that quote, and how does that affect us in our sector, and how are we involving our not only hospital volunteers, but community volunteers in this initiative? Next slide, please, Lisa. Mm-hmm. So the Center for Disease Control has a wonderful website. It's very easy to understand, easy to follow, and if you haven't had a chance to look at it yet, you really should, and we have a link to it in our resources. But they clearly say from the very beginning, the way they're looking at this vaccination distribution process is through 3 lenses. One is prioritizing who gets the vaccine. 2, allocating where the vaccine goes. And then 3, looking at the distribution processes when it gets there. Next slide, please, Lisa. So the Center for Disease Control recommends prioritizing healthcare personnel first. And we've heard this before. This is not new to us, certainly not new to you. And then residents of long-term care facilities to receive the vaccination. Since this original information was written, and the allocation process and distribution process has started, lots of locations have begun to customize their prioritization decision making. And if you can show the next slide, please, Susan. So as the vaccine is allocated to each state, and this is even changing in the next probably couple weeks or so, each state, tribe, and territory develops its own plan for dealing with what groups of people will be vaccinated. Here in California, there was a discussion, and they decided that they were going to add people 65 and over. We started out with 75 and over. There's lots of this talk now and chatter everywhere about making sure that teachers are allocated. So I wanted to ask you a question, if you could put it in the chat, or even if you want to unmute yourself. What additional groups has your state prioritized? I usually would know what states are represented, but I don't today. I apologize. Have there been any other additional priorities allocated in the allocation process within your state to alter who are the priority groups?
Joan, while we're waiting for folks to answer in the chat box, I can share that in May, healthcare workers were prioritized before anyone else. 70 and older was the second wave, and by sometime this spring, they're supposed to open it up to the general public.
So do you have
Marie in Massachusetts notes that now they're allowing anyone over age 65 with two health issues.
Two health issues. And then there's been some talk about if you have a caregiver and the caregiver goes with you, they get a vaccine. I haven't seen that in play anywhere yet, but it's all over the board, this whole concept of allocation, and then we're going to talk about distribution next. So
my sister is a volunteer in Pennsylvania at a vaccination clinic, and as such, she was given the vaccine. And I see we've got a bunch of chats here telling us that it's ranging, as you pointed out, Joan, from state to state.
Well, certainly as we talk about involving volunteers, this is a question and the answer to which we should know, because we want to know if our volunteers are eligible to be vaccinated in your state. So that once the Fed decide how much vaccine they have, they then distribute it to the states. This chart is changing even as we talk, but it's a good visual, and the states then are distributing the vaccine through public health clinics, through retail pharmacies, and through now FEMA clinics. When we gave this presentation a week or so ago, California was the only one with FEMA clinics. Now they have them in Texas and New York. So FEMA is the Federal Emergency Management Agency. Dow's going to talk about that in a little bit. But I put another bubble out there, hospital system clinics. Eventually, but not yet, and those leaders that were on that AHA webinar last week talked about their desire, because so many hospital systems are so large and cover multiple states, and they already have distribution infrastructures built into their operations and logistical operations, they really wish the feds would give the vaccine directly to the system. That's not happening yet. So right now, if you're part of a large hospital system, and one of them covers 26 states that was on that call, they have 26 different protocols they have to follow, and 26 different sets of distribution protocols that they have to develop within that particular system. So if you're within a large hospital system, and you know this already, it depends on your state how things are going to flow through your hospital system when it comes to the vaccination clinic. They also talked about two ways that they are distributing within the hospital systems, but I imagine public health clinics share the same distribution methodology. And one is passive vaccination sites, which we're really more familiar with. You see them on the news, the big arenas or even in your hospitals where they've converted certain parts of your facilities into these vaccination clinics, drive-through clinics. But then what's growing more and more is this outreach vaccination strategy where they're bringing the vaccine, and the hospital systems are doing this and public health clinics are doing this. They're bringing the vaccine to the communities, particularly where there are, they call them vaccine deserts, where the passive vaccination sites don't exist. There aren't a lot of retail pharmacies, or there aren't other ways for residents of those areas. They don't have transportation. They can't get to the clinic. So many hospitals are becoming very creative about using really their population health tools. Many hospitals have health fair buses and almost like a bloodmobile bus that they bring in the community. That's not a new concept. We've had those services for many, many years, but now they're adapting to an outreach vaccination strategy. So these are the conduits for how the vaccine is currently being distributed in the country. And I'm assuming that almost everybody on the call is from a hospital system. So this slide should be of particular interest to you. And we'll talk about this in a little bit, but if you're looking to use volunteers, think about the difference between the volunteers you would use at a passive vaccination site and what volunteers you would use with the outreach vaccination strategy. That would be perfect for social work students and other people that are more mobile. Next slide, please. There is help needed, and the CEOs that were on that webinar really did a good job of describing and bulleting the kind of help that they need. And so I'm sharing their thoughts with you because if they need help, we have help. We've got more workers than, as you know, many hospitals have more volunteers than sick, even though they are furloughed. So they certainly need clinical help, and we could do a whole session on all of the information I'm coming across about staff volunteers. When I see those two words together, it just makes the hair on the back of my neck go up, That's a very interesting dynamic that's happening where not only are we having paid staff, but staff are taking the unpaid time to work in these clinics. They need help with analytics and data. Each one of these things I looked at, and I think interns, students, they need help with community education. And we're experts in community education. We've had programs with community and support groups and patient family advisory support. We know all about that. So that's a natural match for hospital volunteer groups. They need help with logistics. Many of them have developed sophisticated apps now, and if you don't know that the apps that your hospital has developed, you might want to take a look at them because lots of everything bulleted here, in many cases, is being managed through apps that have been developed by hospital systems. So if you do use volunteers here with community education, engagement, logistics, analytics, and even in the clinical setting, the ability to use technology is a skill that is almost a must-have, depending upon your institution. Okay, next slide, please. The other things we have been watching, and this is something that I've been working with for at least now 10 years since the Affordable Care Act came in, is the public-private collaboration, and this is in relationship to the population health. Volunteer groups have always had partners in the community. If we have a Reach to Recovery program, we're partnering with American Cancer Society. There are lots of partners. If we have students, we're partnering with schools. So we're used to this concept of partners. But now it's even more important as you see these distribution systems with public health clinics and retail pharmacies and FEMA. Everybody's at the table together, at least they're trying to be, within each state, to coordinate this distribution of the vaccines. It's a natural skill that we have, most of us in the volunteer sector. Surprisingly, it's not very natural for a lot of hospital leaders. We've been pretty much used to being within our closed walls. And so the ability to flex and work with partners is really important in this distribution process. Caring for the poor and vulnerable populations, I mentioned earlier when it came to the outreach distribution, but caring for poor and vulnerable populations is the core of where volunteerism came from, social work with volunteers. So the need is there. We're used to filling those needs. We may not be there yet, but this is a long-term process. So pointing these opportunities out for you to think about and start to build programming, if anything, in your mind. And then the last thing I want to say on that slide is building trust. The leaders, and I was surprised on that podcast in the AHA, they spent a fair amount of time on this topic of building trust within the community to actually get the vaccine. Building trust not only within their own staff, but within the community itself. Volunteer departments have been natural conduits out to the community. Our doors have always been open. And so we are, it's part of our DNA to build trusting relationships. So that fits our sector too. Okay, next slide. If you do have any questions, I know that many of us in healthcare aren't, I don't want to say allowed, but we need to follow the chain of command. So I don't know if you should reach out to your local health department directly or work within, I would suggest work within your organization to find out who is working with your local health department and get the distribution information directly from them to help clarify your planning and as a planning tool. It's just good to have that kind of information. And you can also share that information with your constituencies too. Next slide, please. I'm going to hand it over to Jared now, who's going to talk about the disaster volunteer world. There are many resources that can be adapted, that you can adapt as a volunteer leader that already are in existence in the disaster volunteer world to write assignment guides, to assist you in this involvement in the vaccine clinic distribution process. And many of you may say, well, this is never going to happen to me. And I would like to suggest to you that if it isn't, speak it out, because this is a crucial opportunity for you to involve the community and involve your volunteers in what was quoted earlier by the CEO, in vaccinating the American public against COVID-19 is the greatest public health feat in our lifetime, and hopefully your volunteers will be part of that. Jared?
Thank you very much, John. And Lisa, if you could take it back one slide, I want to make one comment, which will be a good segue. So Joe's right. If you have questions, you can reach out to your local health department. And what I would suggest is every hospital is supposed to have someone in charge of emergency management. Now, sometimes it's a designated position. You have an emergency management director or some other title that fills that role. And then sometimes, they'll couple those duties together with another position. So you might have your facilities management folks, designate someone on that team to be your EMA or your emergency management director, so EMD, I guess. At any rate, the comment about chain of command is really important. And we can go ahead and move on to the next slide. So in this country, we have a framework for how we handle disasters. It's called the National Incident Management System, or NIMS. The first thing you learn when you learn about NIMS is don't use acronyms, which is funny because then for the rest of the training, they always use acronyms. But that National Incident Management System is what we follow. And what it tells us is all disasters start and end locally. So yes, there might be a pandemic that's affecting the world, but your local community is where that effort needs to start to fix it. And so that's, with things like vaccination clinics or, other local assets that you can leverage. As the incident progresses and it exceeds the local capabilities, that's when it starts to go up to the county EMA or the state emergency management agency. And if it's a public health issue, the state emergency management agency would engage the public health emergency preparedness team from their from the state health department. And so the reason I mention all that is that change mix is really important, because if we don't follow it, then we have people stepping all over each other. And this is where volunteers end up getting caught in the crossfire, because volunteers, will get mixed messages. Everyone come down here. We need people we need nurses. A bunch of people show up. How do they know they're nurses? It might be someone that has more sinister reasons for wanting to be involved in an emergency response. The point is, volunteers aren't supposed to deploy themselves. They're supposed to be deployed where and when needed. And so that's really important for a number of reasons, especially with these public and private partnerships. Now back to the slide here, you see on the top of this wheel, government-affiliated volunteers. Those are public sector resources. And then non-governmental volunteers, this is where most of our hospitals fall. These are private sector resources. And you can see each of these is split up into different categories where volunteers might fall or fit into that model. So back to the top real quick. We've got a number of government agencies that already have planned volunteer programs, including public health programs. And so each of our states, by mandate, are supposed to have their own public health volunteer program that pre-registers doctors, nurses, and other healthcare professionals that can then be deployed when necessary, including private sector places. So there is potential in their state to engage certified volunteers, licensed or certified health professionals that are volunteers to come into your hospital. When they're sponsored by the state like that, hospital privileges are waived, and this is often considered under crisis standards of care. Now, essentially what that means is we break all the rules when we have to. And when there's a crisis, we might change that standard. A good example of crisis standards of care are these groups of citizens that we're designating as priority. During a normal time, anyone can go out and get a flu vaccine. There's no priority for who gets it. But in this case, we have to ration and distribute. And that's a little bit controversial during blue sky times, because people start to get real political about it. Say, well, I don't want someone making a decision if I get a ventilator or not. And that's a discussion that we should have during blue sky times. During a crisis like this, we need to leverage every resource we have to its maximum capability. So back to the slide here, sorry. Each state will have that registry. It's called, which is the Emergency System for Advanced Registration of Volunteer Health Professionals, which is fantastic, but it's a really great example of a volunteer program designed by people that are not volunteer coordinators. The idea is that this registry will be compiled. Thank you. The idea is that the registry will be compiled and ready to go. But as you know, when working with volunteers, if you don't engage your volunteers, you lose them. And they get bored, they change their email address, they move, they wonder why they signed up, they never get any action, so on and so forth. And so although ESRBIP is a really great program with a wonderful intention, it doesn't really get leveraged in the way that I think it was intended to be. If we can go to the next slide real quick. Another federal resource, federal program, I should say, is the Medical Reserve Corps. Now this also, like VSys, is a volunteer program sponsored by, not that it gets a ton of money, but essentially it's community by community volunteer corps of medical professionals. Now that to me sounds a lot like what I just described as ESAR VIP. The big difference is medical reserve corps units can be associated with any profit or any hospital, any county, state, or local department. The idea is to take those pre-registered volunteers, most of whom might be ESAR VIP volunteers, and group them together by their skills or their geographic region, and those teams will train and exercise to do things like vaccination clinics. And typically they're leveraged. You might have a large-scale community vaccination clinic going on, in a gymnasium at a school. And you might bring in a medical reserve corps unit of volunteers to help with that. And some of them might be health professionals that can deliver vaccines, and other folks might have drills in practice to do the other aspects of the clinic, greeting people, sure they do the paperwork, monitoring after they have the vaccine. Those are all non-critical positions. It's really important because each of your communities will have either medical reserve corps units in or nearby, and state volunteers that are pre-registered on the ESAR VIP registry. Now, none of that's any good if you don't know how to access them. And as I mentioned, these volunteers can be brought into your private facilities. And so although we're not used to bringing in outside volunteers into hospitals, during a crisis, this is something that's a common practice. And so if you are worried about the number of volunteers you have available to help with your vaccination clinic, whether it's at a hospital, even a pharmacy could request from the EMA who will send it over to the Public Health Emergency Preparedness folks, even a pharmacy-related clinic could get a volunteer nurse or doctor to help out if they so needed or wanted because of this current crisis. So my recommendation is reach out to your emergency manager in your hospital. Let them know that you're aware of state and local volunteers that might be a good fit if you need them, and that they're pre-credentialed. And if your state is under governor's orders that it's a crisis, most of those volunteers, at least those practicing within the scope of their license, would be covered. The liability would be covered. So if something went wrong, the hospital wouldn't necessarily be sued. It would be the state that takes on the liability. Those risk management things are usually what keep hospital administrators from wanting to work with anyone outside of the hospital. This is a good way to get around that within not just within the law, but according to the law. So if we could go back to the wheel for just 1 second. There's a couple other things I want to mention, and then I can turn it right back over. So again, at the top, you see the black, blue, and light blue pie wedges here. The Citizen Corps, this is where our Medical Reserve Corps falls. And so you might also be familiar with CERT teams or Fire Corps, Neighborhood Watch, things like that. Medical Reserve Corps is part of that program. It's supposed to be a local or regional style program, not a statewide registry. The ESAR VIP folks would fall in that state agency volunteer program. Each state is supposed to have their own registry, not the feds. This is also problematic because we have nurses and doctors that want to cross state lines, and then they're back to square one with not having the credentials or permission or privileges to work in the hospital. And so that's something that you'll want to think about ahead of time. If you're at a border region of a state or multiple states, you might want to consider reaching out to other hospitals, find out what they're doing, and build some of those connections that if you have a state compact where you make a pre-arrangement to recognize other states' credentials, that's another way to bring in volunteer resources. Now, the final thing I want to talk about are the spontaneous volunteers. It's listed down in the public sector. These are those folks that just self-deploy, and often they have the best of intentions, and they might have the right qualifications or experience or education, but if they're not part of that chain of command, if they're not being deployed by an appropriate entity in the chain of command, whether it's local, regional, state, or federal, in the way, and they have the potential to become a victim of that disaster themselves. Not as much in this scenario, but if you think of someone rushing to a flooded area to help out, and all of a sudden their car gets washed out. Now they're another victim, not a volunteer helper, and there's more resources we have to throw towards saving that person. And so it's really important that people don't just show up and say they're a volunteer and expect to work. If they do, this is the big takeaway from my portion of the presentation. If you do have people that show up and say, hey, I'm a doctor, I want to volunteer, the best thing you could tell them is, have you registered with the state's pre-registration program? If they say no, you can direct them, hey, check out the state health department. They've got a program called eSRBIP. Or just reach out to the state health department, let them know you're a volunteer, and they can register you. When we need you, we'll call you. And that's the big thing there. That'll help get around some of the liability and risk management issues that a lot of your administrators are concerned about.
Jared, this is Joan. I wanted to ask you to talk about NOAD, but before I do that, for those of you that are on the call, to put Jared's comments in perspective, when the Medical Reserve Corps was established, it was after 9/11. I was a director of volunteers in a hospital at that time, and our hospital was part of the organizing force through my office of getting those programs off the ground in our area. So if you say to yourself, this is too foreign to me, no, it's not, because you can serve on those committees. You can offer to have the Medical Reserve Corps meet at your institution. There are lots of soft ways that you can partner with these types of organizations that are above the line, with the government-affiliated organizations, working hand in hand with your emergency manager within your organization. And the other thing I want to say is, here in California, the AmeriCorps volunteers are out in force at the public health clinics. Do you have any contact with AmeriCorps? Do you work with AmeriCorps volunteers? There is a possibility they could come into your hospital through your state's AmeriCorps office. So don't discount AmeriCorps also. They are resources if you need them for your clinics. And then VOAD, Jared.
Sure. So VOAD is a voluntary organizations active in disaster. And there's something called National VOAD, which is kind of the umbrella or overarching organization that kind of sets the standards of how they work and what they do. But again, like Medical Reserve Corps, VOAD is supposed to be a community-by-community effort for a state. If you're a small state like Vermont, you might have a state VOAD. Larger states might have it broken up into regional VOADs. But the idea here is there are a number of organizations that we're all familiar with that always respond during disasters. And I'm thinking specifically of the Red Cross, the Salvation Army, Catholic Charities. There's just a big list of familiar names that we all know. Each of those organizations specializes in something. The Red Cross, will work after a fire to help get people sheltered, get them clothes, get them back on their feet. The Salvation Army does mass feeding or mass food efforts where they might set up a food truck or multiple food trucks and feed responders or victims. And so those are voluntary agencies, those are organizations that have pre-plans to deploy, and they have close relationships with the state emergency management agencies and can be leveraged in local, state, and federal responses. And so you don't have to be one of these big national organizations to be part of your state or local VOAD. Your hospital could be part of the VOAD. And that's just a great way to prepare, start to keep this, start this dialogue and keep it going during blue sky times, which is I think the Red Cross came up with that one. The blue sky times are peaceful, normal, happy times, not a pandemic or a crisis. But the more you practice, drill, connect with people during those blue sky times, you'll be better prepared to leverage all the resources available. Again, it's not your responsibility to call MRC or AmeriCorps or VOAD. That really is your emergency manager's responsibility to help get those resources. But if they're not familiar with them, you can certainly pass on the message. I'm looking for something like Medical Reserve Corps or ESAR VEP or whatever other volunteers you're looking for. And to just kind of piggyback and wrap that discussion up, FEMA has recently, within the last few years, created what's called FEMA Corps, and it's an AmeriCorps program that specifically works with FEMA. Now, all AmeriCorps members have a component of disaster preparedness and response that they're supposed to train for. So even if you're an AmeriCorps member working in a library, at least one or two times during your service year or years, you're going to drill with other AmeriCorps members to help with things like, for example, Volunteer Reception Center, VRC. This is another great place to send people. If they show up to you and say, hey, I'm here to volunteer, you can say, hey, did you check the local volunteer reception center that's staffed by AmeriCorps members? They'll help figure out who has what skills, get that information down, and then make decisions about where they might send them. If they have someone there an emergency manager that has that sort of authority, or they can just send on a list of resources to the emergency management agency or the public health emergency preparedness team. So yes, there are lots of programs. They are disconnected quite often, but that doesn't mean we can't leverage them with a little bit of forethought.
And the other thing I wanted to add to Jared's comments is, again, he mentioned it doesn't have to be you doing all this. Many of you have volunteers who have this background or would be interested in serving on a VOAG committee representing your hospital. So think about tapping into your volunteer leadership pool also, and go back to that initial quote that this is the biggest public health feat in our lifetime. It's a stretch. So we're here today to encourage you to stretch your thinking, become more familiar with, if you aren't already, this emergency volunteer world and sector. And remember the other point that the CEOs made: collaboration, community collaboration, partnerships. This is what it's all about now, to address this concept of keeping everyone vaccinated. Going forward, it's big, and there's not enough staff. Our staff are going to go back to their normal assignments, and this is where the volunteers really are going to be needed in the long run.
Okay. Joan, Jared, thank you for incredible insights on the national scene, the local scene, how to engage with local partners. Certainly we encourage everybody to do that, even if, it's just during what Red Cross calls blue sky time. We're seeing a lot of that happening across the country. We're seeing new mutual aid agreements being set up. Jared, is that right? Okay.
Yeah.
Okay.
Not just during, but especially during blue sky times.
Yeah, this is a great opportunity to reach outside of your normal boundaries and engage with the organizations that we're talking about, become part of your local Medical Reserve Corps, your VOAG. There's links to all of that stuff in this presentation, which will be put up on the VSys page. So I asked a question in chat a little while ago. If your organization is not currently using volunteers as vaccination clinics, why? Could you please take a moment and answer that to all participants so that we have something to go on? And I'm going to be addressing very quickly some of the questions you see up on your screen right now. So we certainly believe that volunteers can, even if they are not currently in most of your cases, be called in to staff these clinics through one of the mechanisms that's been described. And you may therefore need to learn more about how points of distribution are structured. So can you progress to the next slide, please, Lisa? As Joan mentioned earlier, the CEOs are recognizing the value of volunteers. They do a lot of some of the stuff kind of mundane, some of it's not so mundane. There's a lot of different roles and models for those roles going out there. Lisa, can you advance some more, please? And my job today is to kind of educate about some of the possible ways that workflow and vaccination flow and people flow happen inside of a point of distribution. And you can either take this information to the C-suite, so to speak, and say, hey, look, I've been learning about this stuff. We'd like our volunteers to be more engaged. They're ready, willing, qualified, and in some cases vaccinated, so let's go to work. Or you can just use it as, good information for yourself, whichever you want. This is one of a great many layouts for a point of distribution that has been tested actually systems out there that I'll be getting the links to in this presentation in a minute, where they look at the population that you're trying to serve, the size of it, the makeup of it, the logistics, the tactics, all that kind of stuff, and will tell you which layout and which workflow and which staffing model is most ideal for vaccinating. And there's been actually quite a lot of work done on that in the public health sector. I've had the privilege of being a part of that over the years, so if you have any questions, please give us a ring. Jared and I can really dive into the details, right, Jared?
Indeed.
So next slide, please, Lisa. This is another one. I kind of like this one because, it puts the screening right in the middle and a lot of vaccination. There's, good space between, the tables, if you will. Of course, a lot of it depends on the space that you're in and, again, the workflow that you're after. But, yeah, can you go to the next slide, please? So there is, as I mentioned, an awful lot of different models out there. There are a lot of different models out there. And the most common is to be, it's probably documented best. I like the state of Oregon's version of it. Jared mentioned the National Incident Management System earlier. This is kind of a page from their book. If you really wanted to get into the details, we'll give you the state of Oregon sheet that comes up that produces this, or that I took this from. And you'll notice in here that for a layout of different positions, kind of a tree here, about half of them are volunteer-centric, or things that volunteers can do, from forms distribution, interpretation, monitoring flows, running things. I actually personally was the command runner for the nation's largest mass vaccination exercise. It was called Pop-Off 3 up in New Jersey many years ago. It was a really awesome experience, absolutely critical role. There's a lot there that could be talked about. We can discuss later if you want to. And there are, of course, many models, but we'll give you links to some. Can you go to the next slide, please, Lisa? All right. This is, if you notice that there were codes next to those descriptions, JAS 2B-6 in this case. JAS stands for Job Action Sheet, and it's a very specific job description related to which position they're in. Each of these job descriptions have been pre-vetted, pre-reviewed, so for liability purposes, you can certainly say that if your volunteers are following the National Incident Management System, Job Action Sheet 2B-6, related to triage, then absolutely there's better liability coverage related to, or potential liability coverage, because they're following protocol. And so, and again, we'll give you the links to some of this stuff in a minute. But this page is only I'm only screenshotting the top third of a 2-page job description that goes into everything that that person ought to have from their qualifications, their background, who they communicate with, who they report to in the system, et cetera, et cetera, et cetera, all of which can very easily be programmed into VSys. And we're happy to help with that. Yeah, Jared?
I just want to jump in and say, as a longtime volunteer coordinator, this is one of the best aspects of the national volunteer effort that I have seen in my time as the state coordinator for Maine's Public Health Emergency Preparedness Team. And you're right, what I wanted to piggyback on was you can take this information and turn it into your own volunteer position description, all of these things, or, like Todd just said, this can be translated into your electronic system, in our case, VSys. And it's great because these are standards. So if you train someone up on one of these, they might be able to go to the next state over and have the exact same job because these are all standardized. And they're really good. They're really specific. So take it away, Todd.
Yeah, no, I mean, these kits that you can get, and we'll give you the links, though, include everything from signage for a point of distribution to all the job descriptions. I mean, this stuff has been thought about a lot. So, next slide, please, Lisa. Good examples here. These are some of the links that I started telling you about. Some of these models can produce the kind of spreadsheet you see up on the left, which is based on the dynamics of your population. Here's exactly how many different people you need to deploy for a pod. If you're trying to vaccinate, X amount of people in Y time frame. Here's how you go. There's a couple of good models for that I'm going to mention. But before I do, Joan actually sent me the link for a good inventory sheet that California uses for trying to establish relationships between organizations who are going to be collaborating in a clinic and for a disaster. And I just like that. And so per all the conversations that Joan and Jared had, download that one if you want to kind of take an inventory of everybody you're working with. We can also handle that information in pieces if you want. The two models that I've been referring to, one of them is, they're both outdated, by the way. Okay, so please talk to your local public health departments for the current stuff. But I think you'll find that the current stuff that they're promoting is somewhat based. It's not very significantly based on one of these two schools of thought that came out of federal grants to either Cornell or Georgia Tech some time ago, several years ago. One of them is called the Bioterrorism Epidemic Outbreak Response Model, or more commonly known as BERM. Sorry, Jared, for the acronym. And there's a link. That one's actually pretty easy to pull down, and it's a very involved interlaced spreadsheet system, so it's Excel. And then you can also apply to get, and it's free, the Real Ops floor plan and staffing model out of Georgia Tech. Again, they're a federal grant. You have to go through an application process to get approval to get it, but it takes a day or two. And I've got it. If you have any questions you want to see it on my screen, I can go into that. Next slide, please, Lisa. So additional resources we want you to be aware of. If you want a good overview of pod staffing models and policies, there's a link here. I think it's lost its link color, but it's still a link. There's a wonderful lady named Olivia Hawks at the University of Pittsburgh who did a tremendous master's thesis actually on everything Jared was just talking about, on how to interlace medical reserve corps, ESAR bits, local operations, hospitals, whatever. There's actually a playbook, okay, on how to do all of that. Also recommend the Big Oregon Pod Field Operations Manual. That's where I took those screenshots from. It has all the signage. Just pick that up, download it. It's publicly available. National organizations, here's all the links, ESARBIT, NRC, BOAD. And then we're also recommending Joan's own presentation on how to structure your own thinking, if you will, on tackling this problem. Okay, she's got a wonderful set of instructions called Plan, Do, Check, Act, which kind of gives you the step-by-step that you need in order to get your head wrapped around this entire problem and how to approach it and how to know that you're actually succeeding when you're making progress as you put all these pieces together. Because it is complicated. And you're really going to have to take, if you will, some time, step back, really study it, over a weekend or something like that. But the potential gains for your volunteer program, not to mention your population, are significant. And I think that's pretty much it. Lisa, one last slide. We do want to make folks aware of some community organizations who might also be helpful. This is in general volunteerism, as well as disaster response, but the Association of Leaders in Volunteer Engagement, or volunteersalive.org. Is that right, Jared?
That's right.
Okay. The National Alliance for Volunteer Engagement and Energizing. These are partners of ours. They have a lot going on, okay, for training you guys as volunteer managers and getting connected with other volunteer managers in your community. So with that, I do believe we are at time where we can open up the mic, if you will, and see if any of you have any questions about any of the material we've talked about, what's happening on a national scene, and how VSys can help. So are there any questions? Please type them into chat.
And in the meantime, I will note that I think one of the key things here is just to make sure that you are at the table when vaccination clinics or volunteers are being discussed. What we're hearing a lot of is that organizations are moving ahead with vaccination clinics, and either they're not thinking about volunteers or they're going around you. So you've got to figure out how to make sure that you are included in these discussions and get involved. Get involved because we know you've got resources.
Yeah, I was just talking to a large national system yesterday, some of their volunteer leaders, and they were telling me how they all got together. They wrote proposals to the national office, and it took 4 tries. They finally found out yesterday morning that their proposal had been approved. And the proposal was simply to start bringing their volunteers back in a tiered fashion. But the lesson to be learned there is persistence, because their management, the CSC, has just been overwhelmed and slammed, and they really, at some point, just can't listen. There's just too much going on. So if you get a no, don't take it as a no. Take it as yes, but just not today, and keep going back with your plans and proposals.
Yeah, and if we can help you put those proposals together, that's what we're here for. You know, we've done that. How many CEOs have you made proposals to, Joan, over the years?
Oh my God.
Yeah, you know, I mean, and Jared and I have been in the trenches with disasters, with politics, with systems, with national protocols, all of these organizations. We could collectively put together a heck of a proposal for you folks. We'd be happy to help out. That's why we're here. That's why VSys pays us.
So on that note, I will remind you all that you should check out the VSys Voices webpage at www.vsys1.com. There will be a copy of this presentation up there, and the recorded video will be up in a couple days. There's also a lot of good information just for you to use as resources. So thank you very, very much for joining us today. And please feel free to reach out to us if there's any way we can help you. And in the meantime, we wish you the best. Stay healthy, and thank you again for being clients of VSys. We appreciate you.
Goodbye, everybody.